Good evening, and thank you all for joining us for this webinar on stroke recognition, education, and prevention. I'm your host, Joel Callahan. I'm the neurologist here at Pardee Hospital. Just a little bit about me. I'm from Mississippi, which is in the stroke belt. So I've been taking care of stroke patients for many years. I was in practice there for 10 years before moving to North Carolina and to this beautiful area. And I've been in practice here at Pardee for the past 10 years. And with me today is Erica Prezis. She's one of our head nurses in the emergency room and a crucial part of our stroke care team. Erica, can you share a little bit about yourself for our attendees?
Of course. Thank you for having me. My name is Erica Prezis. I'm the clinical nurse manager of the emergency department at Pardee. I've been there for about 14 months. I've been a registered nurse for about 17 years, mostly in the emergency department. Prior to becoming the nurse manager here at Pardee, I was the stroke outreach coordinator for 3 years, providing stroke education and resource to a system, facility, and about 18 EMS agencies across Western North Carolina. I'm active in the stroke committee and the subcommittee here at Pardee, and I really look forward to the growth and development of our stroke program and the greater good that it will be for the growing communities we serve.
Thank you. And I'll just say that Erica's been really critical in helping us up our game here at Pardee Hospital. She's been a real asset to both our hospital and to our community at large. And later after the talk, after my part of the talk, Erica will kind of share with what the experience may be like when you come to the emergency room with stroke symptoms and how the process here works. A little bit more applicable to how we do it here at Pardee. So before we get started, I'd just like to point out a few things. As an attendee, you can only hear us, we cannot hear you. So I'll assume that any witty or funny comments I make have landed very well and everybody's enjoyed that part of it. But if you have questions, then please feel free to type those into the Q&A dialog box found on the right-hand side of your screen. You may also find it at the bottom of your screen in some cases. At the end of the talk, we'll be putting up information about our stroke screening. So just stay tuned to look out for that at the end of our question and answer session. So without any further ado, let's get started. All right, so our talk tonight is on stroke recognition, education, and prevention. So what is a stroke? Stroke has been recognized in cultures since the antiquity times. They used to refer to stroke as apoplexy, when people would be struck down suddenly with an inability to move or speak or loss of consciousness with preserved pulses and respirations. And so apoplexy was a term that was used by the Greeks to describe what we would now call a stroke. So this has been mentioned in literature and in medical literature for millennia. But the actual term stroke was only introduced into the medical lexicon in 1968. And when we talk about stroke, what we really mean is a disruption of oxygen supply to the brain in the form of an occlusion of a blood vessel. And that's what we call an ischemic stroke, when there's loss of blood flow. And this is either in the formation of a clot within the vessel or a clot forming elsewhere in the body and traveling to the arterial supply of the brain. If it comes from another part of the body and goes up into the brain, we call that embolic. So ischemic strokes may be embolic or just due to occlusion of the vessel itself. The other types of strokes can occur when there's a rupture of a blood vessel, or what we would call a hemorrhagic stroke. Most strokes, around 85%, are ischemic, and that's going to be the focus of our talk tonight. Sorry. So with an ischemic stroke, and again, that means that there's just a disruption of blood supply. You see the arteries here in the neck, in this area here. So this would be the carotid artery. So a normal carotid artery doesn't have any disease in it and blood flows very smoothly. In a diseased carotid artery, there's plaque buildup in the wall of the vessel. This can lead to formation of clots, and those clots can break free and then travel up the artery and cause an occlusion downstream. So traveling up the artery here and causing an occlusion here. With an embolic stroke, this occurs when when a clot comes from another part of the body and travels to the brain, usually from the heart. So in people that have atrial fibrillation and an enlarged left atrium, a clot may form here and then travel into the heart and then out into the brain. Or some patients may have a little hole in the wall of the heart here and a clot that comes from somewhere else in the body, perhaps in the leg, from a deep venous thrombosis, and travels into the heart and then up into the brain that way. So the clinical signs of a stroke really depend on which part of the brain is affected. There are several functions that are performed by the brain, so the signs and symptoms of a stroke will depend on the region of the brain affected by the disruption of blood flow. Since the since the beginning of humanity, as long as there have been head injuries and wars, people have recognized the fact that certain parts of the brain do certain types of functions. And even in the 19th century, many scientists or philosophers would outline regions of the brain based on what they thought they controlled. So here's a picture that was drawn by Gall in the 19th century, looking at different kind of personalities or regions of the brain and what they controlled and what they understood at that time. But in modern day, we understand now that that looks a little bit different. The front of the brain here is mostly responsible for motor control and planning and executive function, whereas the more posterior part of the brain has to do with senses, touch and pressure, language, vision. And the temporal lobe here is really our language center, hearing, facial recognition, and then coordination is more in the very bottom back part of the brain here. So if you have different parts of the brain that is affected by an occlusion, then they'll have different symptoms depending on what part of the brain was affected by that lack of blood flow. The circulation to the brain is very complex. So the circle of Willis is what we refer to as this structure here that allows blood to flow both from the bottom part of the brain and from the front part of the brain. And there's interconnection of these vessels that allows blood flow to go pretty much anywhere it needs to go, depending on the needs of the brain. So there's a lot of redundancy of circulation in brain tissue, which is to our benefit. Sometimes people can have an occlusion of an artery that happens over time and never have any signs or symptoms from that because there's good collateral flow or flow that goes around that blockage that allows that brain tissue to be salvaged. And here's another diagram looking at the blood supply to the brain. So here you have your carotid artery that supplies the front part of the brain here. So this will be your executive planning part of the brain, motor part of the brain, and some sensory parts of the brain. Then you also have what we call the basilar arteries that come up from in the back of the brain, the vertebral arteries, and come into this basilar artery here that supplies the more posterior part of the brain, coordination in your brain stem. But these two connect. And so if you have an occlusion up here, you may be able to get blood flow from the very back part of your brain there. But you can see how intricate this is and how well supplied our brain is with oxygen because it just demands so much oxygen for its function. So the signs and the symptoms of a stroke are hard to sort of remember all the different things that the brain does and how that may affect you. So the American Heart Association, along with other groups, have come up with these acronyms, and BFAST is the acronym that we are currently trying to make people aware of. And what BFAST stands for is B is for balance. So a sudden loss of balance or coordination, that would be in the back part of your brain being affected. Eyes is E, so a sudden loss of vision in one or both eyes, or even a sudden change in vision with double vision. F is face, so sudden weakness on one side of the face. Arm is A, or appendage, so a sudden arm or leg weakness or numbness. S would be speech, so speech change with trouble speaking or slurred speech or difficulty with language. And then T is time, because time is of the essence when we're talking about preserving brain function, and we'll get to that in just a minute. So how does vascular damage occur? Well, the blood is, the brain is supplied by blood vessels just like the heart is, and a lot of people are very familiar with how heart disease occurs. And so the risk factors for vascular disease in the brain is really no different. Hypertension is one of the most common reasons that people have arterial disease, and We try to make sure that people's blood pressure is controlled to about 120/80. Diabetes mellitus is another cause of vascular disease that can lead to stroke, and that can affect both larger and small blood vessels. Elevated cholesterol, so total cholesterol greater than 240 or an LDL greater than 160. Tobacco use, and then things that we really can't control like age and genetics, and then things that are definitely under our control such as lifestyle. So again, tobacco use would be in that category. Diet, obesity, a sedentary lifestyle, and excessive alcohol use. And drug use would be in that as well. So why is time so important? Once nerve tissues are deprived of oxygen, this is in any part of the body, injury and death can occur within minutes. So in the brain, you have an initial core of injury that does not reflect all of the tissue that's at risk. So you may have a small area that's immediately damaged by a lack of blood flow, but you have a larger area that is at risk and potentially salvageable. And we refer to that larger at-risk area of the brain as what's called the penumbra. And the penumbra can be saved if blood flow is restored quickly. So the concept of a penumbra is best visualized when you think about like a shadow. And this is the sun and the moon, or the sun and earth, talking about the penumbra of the shadow that's cast by the earth when the sun's behind it. And so the penumbra is this sort of gray area where there's not complete darkness, but there's some shadow that's cast. And so the penumbra, when you talk about brain tissue, is that it's the area that's not damaged immediately by the lack of blood flow, but it's an area of sort of watershed where there's a risk of that tissue dying. It's not getting all the blood that it needs, but it's not quite to the point that it's losing its oxygen supply to the point of cell death. And this is the part that we are trying to preserve when we are talking about the time factor for strokes. So how do we treat a stroke? Well, we have new medicines, well, not new medicines, they've been on the market now for 20 plus years, but we have treatments that are very time sensitive and really meant to restore blood flow to that at-risk territory. So people refer to these as clot busters. We call them tissue plasminogen activator, or TPA, or alteplase. And these must be given in a timely fashion within 3 to 4.5 hours to avoid the risk of bleeding. The brain is an organ that is very prone to bleeding, and so if you have tissue that's been damaged and injured and starting to kind of break down, then it doesn't take a lot for that area to start to leak and bleeding to occur. So the sooner TPA is given, the more at-risk tissue in that penumbra is rescued, and the less risk there is for bleeding. And with TV shows and some dramatic stories, we think about TPA being given and people jumping up off the stretcher and just getting back to normal within minutes. And that does sometimes happen, but really TPA is given to help reduce the risk of morbidity, mortality, and disability at 3 months. And we know that people that receive this medication do far better than the people that don't receive this medication. It just has to be given in a very timely fashion. One of the newer and more exciting treatments of stroke has to do with embolectomy. And so we talked about an embolic stroke a little bit earlier. So an embolectomy refers to retrieval of a clot that's lodged into a vessel by mechanical means. And these are typically catheter based. And these can be used for what we call large vessel occlusions. So if you have a large blood vessel that's occluded by a clot that traveled, say, from the heart and blocked off blood flow, then you can put a catheter into an artery and use a device to retrieve that clot and restore blood flow directly. And then with any acute treatment of any medical problem, we talk about the ABCs, about maintaining airway and blood pressure and cardiovascular system. With blood pressure management, we don't want to lower their blood pressure too much. We want to make sure that there's good perfusion, but we still have to be very mindful about what people's blood pressures are, because the higher the blood pressure, the greater the risk is for bleeding. And then treatment of hyperglycemia. So sometimes having elevated blood sugars can actually mimic a stroke, in which case the damage is a little bit different than a lack of blood flow. But also hyperglycemia can cause damage to the nerve tissue itself. When we're treating somebody acutely for a stroke, we do different types of imaging modalities. And so the point of this slide is to help y'all understand what scans may be done and why we do different types of scans. And so a CAT scan can be done very quickly and easily in the emergency room. They can be done within minutes. And they're really good for ruling out bleeding because a bleeding stroke needs to be treated differently than a non-bleeding stroke. We can do an arteriogram. So people may be familiar with arteriograms where the catheter is put into a groin and a vessel's imaged from the inside. But now with the sophistication of CT scans these days and the high resolution we have, we can actually get very detailed pictures of the blood vessels very quickly without doing any sort of invasive procedures, and take a good look at the blood flow supply and see if there's any occlusion within minutes. And then there's CT perfusion. And these are scans that look at the amount of blood flow that's getting to parts of the brain so we can see where is that core of injury and where is the penumbra and how much tissue may be salvageable in this particular patient. And then MRI scans are very good at giving us detail. They take a lot longer to do, but the resolution that they give and the data that they give us is much greater. And so they also play a very crucial role, sometimes in the acute treatment, but a lot of times they play a role in the further management and diagnosis of stroke. And then there's secondary imaging techniques such as echocardiogram to look and see what the function of the heart is, to see if there's any vascular problems in the carotid system that maybe we didn't see on the CT arteriogram, or didn't have an opportunity to do a CT arteriogram, or wasn't appropriate for that patient for some reason. So this is a picture of a CT arteriogram. And what you see on this side here is that you've got nice blood flow, and these vessels are filling up with blood flow on the right side of the brain. But over here on the left side of the brain, there's an abrupt kind of stoppage of flow. And so that's an occlusion of that blood vessel. And on a regular CT scan, sometimes that clot shows up as a very bright spot. You may not be able to see it as clearly here, but that's what this image represents. So the CT arteriogram can help us find out where the vessel may be occluded, and that patient may be a candidate for having embolectomy performed. This is an example of a CT perfusion scan. CT perfusion is very exciting. It's been on the market for a few years. We've had it here at Pardee for the past 2 years, and it's just become a key instrument in helping us with timing and treatment of people with strokes. So in this particular example, the red area here represents the tissue that's already been damaged and is probably not salvageable, but the green area around that is tissue that's at risk, and that would be what we were trying to salvage by restoration of blood flow, either through catheter-based embolectomy or through TPA. And so the CT perfusion can help us see if a patient, maybe we aren't sure how long their symptoms have been present, or maybe they're out of that 3 to 4.5 hour window of getting TPA, but there's still a big mismatch between their area that's already been damaged and the area at risk. And so even without knowing the time of the patient's symptoms onset, or they're out of the window, then we can safely give them a treatment such as embolectomy to help restore blood flow. And this is an example of an MRI scan. So when an MRI scan is done, there are several different types of images that are collected. This particular image is called a diffusion weighted image. And it looks at an acute change in or shift in water concentration in the brain. And so when there's a stroke that occurs, those cells die and they release water into the tissue around it. Oops, sorry. And so you see that it's a very bright white spot on an MRI scan. And you can see this change within minutes of injury to the brain. You may not see this on a CAT scan, and you may not even see it on other images of an MRI scan, but you can see that there's been some damage there within hours, within the first few minutes of the stroke. So for acute stroke treatment, we talked about TPA, and it's a wonderful drug. It's a huge part of our toolbox for treating acute strokes, but not everybody qualifies for TPA. Because you're giving this medicine that breaks up blood clots, for patients that are at risk of bleeding, they may not be candidates for getting TPA. If they've had recent surgery, they may not be able to get TPA. Or if we aren't really sure when their symptoms started and we can't document that 4.5 hour time window, then they wouldn't be a candidate for TPA because of the risk of bleeding that we talked about a little bit earlier. So if the time of onset is greater than 4 hours, 4.5 hours, or the time is really not known, then that patient may be a candidate for embolectomy. So embolectomy requires a team approach. It requires an individual radiologist, and it requires a radiology team and a neurologist to make the assessment. And so we collaborate in our region with Mission Hospital because they have the interventional radiology resources there 24 hours a day, 7 days a week. And so for the past 2 years, we've been working with Mission with teleneurology, where we have a robot in our emergency room. And if we have a patient that's potentially a candidate for this embolectomy treatment, then we can reach out to the neurologist at Mission, and they can make an assessment, look at the scans that we've done, including the perfusion images, and see if that patient may be a candidate for embolectomy. And if so, they get transferred emergently up to Mission. And within minutes of getting there, they can have this procedure performed. And we've had several patients that have done extremely well because of this coordinated effort and use of technology. Sometimes people come in with signs and symptoms of an acute stroke, and we think they may be a candidate for TPA, and then suddenly their symptoms get a lot better. And that would suggest that there's been reperfusion of that area at risk by the body's own physiology. So it broke down the clot itself or restored blood flow on its own. And so that's what we call like a TIA, or a transient ischemic attack. A lot of people refer to this as a mini stroke. By definition, a TIA is a stroke-like symptom that resolves within 24 hours. And with some of our more sophisticated imaging techniques, and we would view that as not leaving any sort of footprint behind on an MRI scan. If we see that there's been cell injury or death on the imaging studies, and we would still call that a stroke. But a TIA is still a significant event. It still needs to be taken very seriously, even though the symptoms have improved. And so patients that come in with a TIA where their symptoms have resolved, many times we will admit them and work them up as they've had a stroke, and try to identify their risk factors and make sure that they're not at risk of having another event within the next several days when they're at the highest risk of recurrence. This slide is just to kind of walk through again the different steps that we have for treating acute strokes. So over to this side over here, you can just give an IV therapy, which is what TPA is, and we can do that, and we do that very often in our emergency room here. Sometimes it requires a combination of therapy. So we give the patient TPA here. We do our studies and we see that there's still a large vessel that's occluded. And so that patient would go on up to a tertiary care hospital where they have embolectomy available in our area that's Mission, and have this other procedure performed. And then some patients aren't really a candidate for the TPA, so they just go to the endovascular treatment and go to the cath lab and have their treatments done that way. After the patient has been assessed and whether or not they've gotten TPA or some other treatment for their stroke, the next steps of preventing further strokes have to do with kind of more long-term medications. So patients that have those typical risk factors for vascular disease, where they have primary small vessel or medium-sized vessel disease, then we'd put that patient on an antiplatelet agent. So platelets are sticky cells that allow damaged vessels to close up. So when you cut yourself, platelets are responsible for keeping you from bleeding to death. But platelets can also stick to surfaces that aren't exposed to the outside, and then that clot occurs within the vessel wall, and there's an occlusion. So when we keep platelets from being so sticky, that can reduce the risk of stroke. And so we may use antiplatelet agents such as aspirin or Plavix or even Agrinox. And for patients that have recently had a stroke, we'll use a combination of those for a few weeks to reduce their risk of having a recurrent event. So if you came in and you weren't taking any medication and you had a stroke, then you would most likely leave on something like aspirin or Plavix or both of those. For people that have atrial fibrillation, where their heart rate is irregular, then they're at risk for a different type of clotting problem. So if you think about blood sitting in a bowl that it's going to congeal on its own, if you have a weak heart muscle or you have an ineffective way of pushing blood out of the heart, then the blood that's sitting in the heart is going to form a clot just like it would if it was sitting in a bowl. We call that the intrinsic pathway. And so antiplatelet agents don't work as well from keeping blood from clotting together that way. And so we use anticoagulation. So those would be medications like Coumadin or Eliquis or Xarelto or some of these medicines that you may have heard of. And so for patients that have AFib or have had embolic events, then they may not go out on an antiplatelet agent, but rather go out on an anticoagulation agent. And then statins, I know that there's sometimes a lot of controversy about statins because they do have some side effects with them. But statins have been shown to reduce the risk of recurrent stroke independent of the effect on cholesterol. So we would have a goal cholesterol of an LDL of less than 70 for somebody that's had a vascular event such as a stroke. But statins have been shown to reduce inflammation in vessel walls and reduce plaque buildup. And so they are a very pivotal part of our post-stroke treatment plan for patients for reducing the risk of stroke. Then blood pressure management. Initially, we want the blood pressure run a little bit high the first 24 hours or so to maximize perfusion. The brain knows what it wants, and so when it's not getting oxygen, it's going to ask the heart and the vascular tree to give it more blood. So the blood pressure is going to rise a bit in somebody that's having a stroke, and we want that to happen as long as that pressure is not too high, somewhere around 200 over 110 or less. But the long-term goal would be for the blood pressure to be about 120 over 80. And so if somebody has a history of hypertension and they're not on medications, or their blood pressure is not adequately controlled with medications, then that would be a risk factor that could be targeted after a stroke. And then blood sugar management for diabetics. And that's done as a combination of acute treatment in the hospital and then long-term management with the primary care doctor once the patient leaves the hospital. Then other studies that may be done or things that need to be addressed would be heart rate and rhythm monitoring. So sometimes patients don't have any identifiable risk factors for a stroke, but they've clearly had one. And so they may be having an abnormal rhythm in their heart that's just not there all the time. And so those patients would be put on telemetry monitoring here in the hospital, but many times we'll ask them to wear a heart monitor when they go home. Up to 30% of patients that have a stroke of unknown cause, if they wear a heart monitor for a month or more, we may see that they have intermittent atrial fibrillation. And so that would be a risk factor that could be modified and managed by identifying the culprit. And so we sometimes have people either wear an implantable device that goes into the skin that keeps an eye on their heart rate rhythm, or a wearable device that has sticky pads that they wear for a few weeks and then turn back into the clinic. Swallowing safety. We know that patients that have had a stroke may be at risk of having aspiration, and then getting an infection on top of a stroke just leads to more morbidity and mortality. And so we always do a swallowing assessment for patients that come in with stroke. We try to identify rehabilitation needs. Some people get much better with treatment and with time, and they can go home and get around safely. Other patients need more intensive therapy to regain strength and balance and coordination and safety. And so we may make recommendations for them to go into an inpatient rehab facility or to go home with home health to make sure that they're getting the therapy that they need to recover as fully as they can from their stroke. And then tobacco cessation. This is hard to emphasize enough how important it is to stop smoking in somebody that has vascular disease. Obviously, not starting smoking is the best way to prevent that. But for patients that come in that have been smokers, then we really try to emphasize the need to stop smoking. Other risk factor reduction has to do with healthy lifestyle, so maintaining appropriate weight. Walking is just such a key part to a healthy lifestyle in so many factors. It's been shown to improve cognition, reduce the blood sugar, lower heart blood pressure, and improve vascular health. A healthy diet, such as a Mediterranean diet, limiting tobacco, limiting alcohol use. Those are all parts of a healthy lifestyle. And then medications, we talked about blood thinner, managing blood pressure medications and cholesterol medications and diabetes management. Routine cardiac monitoring, so maybe wearing a device like we talked about. Maintaining good sleep, making sure that there's not sleep apnea. We know that sleep apnea, not only does it not allow for restful sleep and can lead to memory problems and just a poor quality of life, but untreated sleep apnea can actually put a strain on the heart and increase your risk of stroke. So when your doctor talks about getting a sleep study done, there are many health factors that may be mitigated by healthier sleep. And then maintaining a routine follow-up. You may go out on all the right medications and have all the best intentions, but without checking your blood pressure, without making sure your diabetes is under control, without checking your weight and talking about risk factor reduction going forward, then sometimes people can fall back into bad habits or just have untreated or unmanaged medical problems that increase the risk of stroke down the road. So why does this matter? Why are we talking about stroke? Well, stroke is a very prevalent disorder in our community, in our country, in our county, and as part of the country, it's everywhere. It's responsible for 1 in 6 deaths from cardiovascular disease. Someone in the United States has a stroke every 40 seconds. Every year, more than 795,000 people in the United States have a stroke. 600,000 of those are new strokes. 185,000 people have had strokes before that have a recurrent stroke. As we talked about earlier, 87% of all these strokes are ischemic strokes in which blood flow to the brain is blocked, and those types of strokes are particularly treatable by risk factor reduction. The cost of care for stroke is very high, $46 billion between 2014 and 2015. And that's missed work, that's healthcare expenses. That cost is only going to go up because these imaging techniques that we talked about weren't as prevalent in 2014 and 2015. They help improve our care of stroke, but they're also expensive. And so vascular disease in general just carries a heavy economic burden to our society. And stroke is one of the leading causes of long-term disability. If people are paralyzed on one side of their body, then it decreases their quality of life and leads to long-term other medical problems. It reduces mobility in about half the people that survive strokes over the age of 65, puts them at risk of falls and broken hips. And so preventing a stroke is the best way to keep from having long-term disability from a stroke. But acute treatment of a stroke is very helpful in reducing that disability, as we talked about earlier with TPA. So one of the things in neurology that we've had a difficult time with is that we don't have Fred Sanford that grabs his heart or grabs his brain and says, I'm having a stroke. Everybody knows about what cardiac disease looks like. They know what chest pain and angina means, and those patients get to the emergency room right away. The biggest challenge that we continue to have, even in 2021, is that patients just don't show up in time for us to give them appropriate and aggressive treatment. So again, I encourage you to remember the signs and symptoms of a stroke, which is BFAST. Balance, sudden loss of balance or coordination, sudden change in vision, sudden weakness on one side of the face, sudden weakness or numbness in an arm or a leg, speech changes, and then remember that time is of the essence, because every second that the brain goes without blood flow, then there's more cells that die, and every minute that we can give that TPA fast to reduce some sort of individual treatment, there's more brain that's salvaged and less disability and long-term effects of the stroke. So I'm going to turn this over to Erica and let her describe to the experience that you may have in the emergency room and what it's like to come to the emergency room with a stroke, and then we'll move on to our question and answer session.
Thank you. So early recognition is key, as Dr. Callahan was mentioning. So the faster you recognize and get to the emergency department, we would like for you to call 911, but if the faster you can get there, however you can get there, that is key. Patients enter with the signs and symptoms of a stroke. It's recognized early on by the trained staff at the triage area, or if you brought in by EMS, they call us with a heads up and give us an alert that a patient with a potential stroke is coming in. You might hear the term stroke alert that is used by the staff to try to get everybody to the table to act fast to ensure treatment is started right away. The patient will see one of the physicians, nurse practitioners, or PA early on in at the arrival. Neurologist will be paged or called via telephone to ensure the specialist is involved early on in the care of that patient. While neurology is being called, the patient should anticipate going to CT rather quickly, or CAT scan, one of the terms that Dr. Callahan spoke to earlier about the imaging of the brain to determine what kind of stroke the patient is having, what treatment options are available, or if other physicians or providers need to be alerted and involved in the care of that patient as well. The neurologist will then see the patient either in person or via telemedicine, as Dr. Callahan mentioned, and what we call our robot, our stroke robot. That is our platform that we use with telemedicine capabilities. Even then, a patient may actually see both. Once they're seen in person by Dr. Callahan or one of his colleagues, they might be seen on a robot if they are able to get embolectomy, or they require embolectomy at a facility that performs that. We partner with Mission Neurology and Mission Health to ensure the patient goes to the right place at the right time for the right treatment options. Some strokes are amenable to neurovascular treatment options, such as the embolectomy. And then we do not offer that service here at Pardee, so they are emergently sent to Mission where they can have that performed. We're very fortunate to have the resources available for the community through this partnership. And depending on the results of the CT scan and what kind of options that Dr. Callahan or his team decide on, the patient may receive a clot busting drug that he spoke of, the TPA or alteplase, in our emergency department. They may be emergently transported or transferred to Mission for embolectomy, thrombectomy procedure. They may receive the treatment of the clot busting drug and stay at Pardee for observation and further treatment. They'll be admitted to the ICU, or if they don't receive the medication, but they do require observation and further treatment of their lesser acute stroke, they will go to our progressive care unit. And then the care team, along with the patient and their family as well, will determine the right treatment for the patient.
And it's important to note how Erica's just been a really big asset to us, improving our process. And it's a real team effort, not just with Erica, but there's a whole stroke committee and a whole stroke team that's involved in constantly improving our process. And it just takes so many people to help us do this. And I'm proud to say that we've been recognized for that. So there's a kind of a metrics, quality metrics called Get With the Guidelines. And Pardee Hospital has been a Gold Plus recipient with those guidelines for the past several years. And it's just an ongoing effort to improve our care, not just at our hospital, but making sure that the care in our community is consistent. That's why having a regional approach to stroke has been so important, and working with Mission and that outreach and coordinated effort. So I hope that y'all have enjoyed and found this to be educational. If there are things that we did not really address adequately in the talk, then I guess it's time for questions. And Erica, do we have any questions?
We do. We have quite a few. Donna asks if there's a connection between, or what is the connection between retinal occlusion and very random AFib with PACs? Is it always cardiovascular, or could it be related to a neurological problem?
So retinal occlusion, that's actually very interesting that she asked that, because there's a sort of a kind of an awakening happening in the stroke world that retinal occlusion should be treated as a stroke. And so there's a big push to make sure that those patients are assessed and given the same opportunity for TPA, if it's appropriate for them, as would somebody that comes in with paralysis on one side of their body. The problem is that retinal occlusion sometimes go to the ophthalmologist first, and it may be several hours or even a day or so before they kind of come to the neurologist's attention. So as difficult as it is sometimes to get somebody that's paralyzed on one side of their body into the ER within 3 hours, it's even more difficult sometimes to get somebody with a sudden vision change in. But that retinal occlusion can occur with carotid disease. So the carotid artery supplies the eye. In fact, the first branch off the carotid artery, internal carotid artery, is the ophthalmic branch. And so loss of vision, we always look at the carotid arteries to see if that's the culprit, but it can be associated with atrial fibrillation as well, just like any other stroke risk factor. And then the treatment would be determined based on what that underlying risk for that patient was.
Wow. So Shay asks if any of the symptoms are the same, or are the symptoms the same for both men and women?
Yeah, so even though it may not seem that way, that our brains are very similar between men and women. So the way the brain's laid out and the areas that are particularly at risk for stroke are the same. So that BFAST acronym would be appropriate. Now, the risk factors may be different for women compared to men, especially young women that smoke, that are on birth control. They have a much higher risk of developing blood clots. So that would be something that's unique to women. And then as men age, we are a little bit higher risk of developing vascular disease across the spectrum compared to women. So there are some age risk factor stratification and sex risk factor stratification that differs, but the signs and symptoms would be the same. And the treatment really would be the same across that spectrum.
So Amanda asks how likely someone would be to fully recover from a stroke.
Well, it depends on how severe the injury is. And so we talked about that core of injury and that penumbra. So if the core is very small, then the brain actually does have a lot of what we call plasticity, where the nerve circuits can kind of regenerate and make a pathway around that area that's been damaged. And That's why rehab is so important early on in the stroke, because it kind of teaches the brain what it needs to do and allows it to make circuits and connections that allow recovery to occur. Sometimes a small stroke, though, can be very disabling. So if you think about back to that picture of the brain where all those different parts of the brain were scattered, and then you look at that little brain stem that's coming out of the bottom of it, all those nerves and all those big organization parts of the brain eventually get down to that little brain stem and go out into the body. And so I always kind of think about it as a clown maybe holding a bunch of balloons, that all those balloons are up in the air in a big cloud over the clown's head, but there's one little bitty parts of strings that are in his hand. And so you can have a very small stroke in a very integral part of the brain and have a lot of symptoms. So the recovery and the amount of recovery depends on the area that's affected and the size, and then how much good tissue is around that to make new circuits, and the kind of rehab and effort that the patient is able to put into that rehab process.
Great. So if someone comes to Pardee and has to get transferred to Mission afterwards, will they have to go through the whole process again and be re-examined?
I'm sure that you can answer this question better than I could, because you're in there in the ER when this happens. But no, whether the doctor at Mission, the neurologist at Mission, is either on the robot and has already kind of seen the patient in our emergency room, or whether it's a phone call and we describe the symptoms and they have a chance to look at the films. Once that patient is there and has been accepted, then the assumption is that they're going off to have a procedure done. And so there may be very minimal amount of kind of getting a quick history and a quick exam to kind of see where the patient is. But the goal of that transfer is to get treatment quickly. And then the process of being admitted and kind of doing the rest of the medical workup would take place after that. So we wouldn't want to shortchange a patient on time for kind of bureaucratic and paperwork. The goal is to get treatment into the patient and get the clot out and blood flow restored.
Right. So Alan asks, can someone have a stroke while sleeping?
Absolutely. Sometimes the strokes that occur while sleeping are hemorrhagic. So we'll see people that have the bleeding types of strokes when they're sleeping, but atrial fibrillation can cause a stroke at any time. There's a whole sort of subset of strokes that we refer to as wake-up strokes, where people have woken up with symptoms. And that becomes a challenge, because we talked about that time of onset, that 3 to 4.5 hour window for getting TPA. And so the slide I showed that looked at the perfusion study, where there was an area that was damaged and an area at risk. If we're not sure when somebody had their stroke, but we see that there's that mismatch, then they're still a candidate for embolectomy, even if they may not be a candidate for TPA. So wake-up strokes are common. They can be a diagnostic and a therapeutic challenge, but with technology and this sort of coordinated approach, that we are much more able to deliver that care and offer that patient something that they would not have had available to them even 5 years ago.
Great. Also, are there any warning signs that people should be aware of prior to having a stroke?
Well, so the signs, so we would call a warning sign like a TIA or a mini stroke. And so they would be the same type of symptom that you would have with a regular stroke. The only thing I would encourage you is if you have a sudden onset of symptoms that have to do with a loss of function, so a loss of balance, a loss of vision, a loss of sensation, a loss of strength, loss of coordination, if something like that comes on suddenly, even if it passes quickly, within 5, 10, 15, or 30 minutes, I would encourage those patients to still get to the emergency room, because that may be the warning that they're going to have a stroke, and that blood vessel that became occluded and opened back up again, it may occlude again. It may be very much at risk. Even if those symptoms were brief and maybe didn't get your attention, if they recur over the next several days, and that may be a sign that there's an artery that's got some plaque in it that's breaking off and causing strokes. And so any sign or symptom like that warrants a trip to the emergency room, calling 911, or at the minimum, reaching out to your primary care doctor and discussing it with them. But I can't emphasize enough that getting to the emergency room, letting us assess you within the first, as soon as you can after those symptoms occur, is the best way to prevent and treat a stroke.
Thank you. So Edna says there's guidance for taking aspirin in case of a stroke, but if one is having a bleeding stroke, wouldn't that do more damage?
It could, and there's been there was an article that came out in the New England Journal several years ago that talked about the fact that aspirin is not really good for preventing cardiovascular disease, and that it's a little bit misleading because it talked about patients that don't have any known risk factors, perhaps, for that. And so there's been this sort of a lot of people stopped taking aspirin when that article sort of hit the news. If you're having a bleeding stroke, then of course an aspirin would not be indicated in that situation. If you can take an aspirin though, it still would be better off to do that, or just get to the emergency room and let us do the imaging studies and make a decision for that. A lot of times if somebody's taken an aspirin before they've come in, then we will give them something like Plavix to take with that to sort of double up on their antiplatelet therapy. But the more important thing would be just to call 911 and come in and not worry about whether or not you need to take an aspirin, but just get to the hospital as quickly as possible.
I agree. So you mentioned BFAST, the acronym for stroke recognition, and Jim wants to know if the B and the E in BFAST are more significant.
The B and the E so it used to be FAST, and now it's BFAST, because a lot of times patients have these sort of vertigo symptoms or coordination symptoms, and that acronym FAST wasn't enough to get people to recognize the signs and symptoms of a stroke. So I wouldn't say that they're more important, but the BFAST acronym is just more inclusive and actually does a better job of capturing all those different regions of the brain that may be affected with the stroke.
So what are the chances of somebody having another stroke after they've had one?
Well, it depends. I get asked that question a lot. And so the answer I usually give the patients when we're talking about this is that hopefully if we're doing our job right, your chance of having another stroke is way less than the chance of you having a stroke before you came in, because there's some risk factor that maybe wasn't being modified appropriately. And with proper risk factor reduction, so managing your blood pressure, your diabetes, or stopping smoking, then the risk of recurrent stroke goes down considerably. But there are some patients that just have genetics that make them very prone to vascular disease. And so we do the best we can and try to modify those risk factors. But even with the best efforts, sometimes patients still will have recurrent events. But I would say the goal of treatment and the goal of medical management and continued medical care is to make that risk zero for recurrent stroke.
Is there a test to evaluate someone's risk, like evaluate their carotids perhaps?
Actually, there is. And at the end of our talk, we're going to talk about our screening clinic that's going to be available later this month. But, blood pressure is called the silent killer. And so patients may not even know that they have hypertension unless they check it. So one of the easiest things that you can do to look for your risk of stroke is to make sure your blood pressure is checked. And you can do that with a home cuff. Or just, with your regular visits to your primary care doctor. And then, stopping smoking, I mean, that's an easy one to address because that has a very strong link to vascular disease. But as far as other screening tests, a carotid ultrasound, looking for buildup of plaque in the carotid arteries would be a simple test to do. It's not expensive, it's not invasive. Not everybody would need an echo to look at heart function, but certainly having an exam where somebody checks your pulse and listens to your heart rate and asks the right questions about fluttering in your chest or chest pain might lead to that test being done. So I would say blood pressure checks are really important, making sure that there's no diabetes because that can also kind of be silent for many years before it starts causing problems. And then screening with an ultrasound of the carotid arteries, perhaps an echocardiogram at some point.
This one is interesting. Irene wants to know if she's more at risk for dementia if that she's had one or two strokes, or anybody.
So the easy answer is yes, you would be more at risk. So there's a sort of a subset. With dementia, you have to think about it as being an umbrella term. And so there are lots of different types of dementia. There's Alzheimer's disease. There's dementia that's associated with Parkinson's disease. Alcoholics can get dementia from alcohol abuse. And so there's a vascular dementia. And with vascular dementia, it's the patients that have maybe silent or they aren't really aware of the amount of small vascular damage that they've had to their brain, but the little hits that occur where they have small parts of their brain damaged, adds up over time, and the function of the brain starts to go down. And so we think about these patients having this sort of stepwise decline in their cognitive function because you have this maybe event that occurs that doesn't give you typical signs or symptoms of a stroke, but cumulatively there's this sort of staircase decline of cognitive function. So anybody that comes to see us with memory complaints, then we will always do a scan, a CAT scan, or more preferably an MRI scan, to look and see if they have a vascular load there, because those patients, if they're not being adequately managed and modified with the risk factors, that gives us an opportunity to not only reduce their risk of stroke, but what they came to see me for was their risk of memory problems, is trying to decrease the risk of that getting worse as well. So that's a great question.
I think we only have time for one or two more before your talk about prevention and screening. So what screening tests should someone have and how often? If you look at Medicare guidelines and what your primary care doctor does with your annual wellness check, those hit sort of all those vascular marks. So really one of the best things you can do is just have a routine visit with your primary care doctor to make sure that your blood pressure is checked and that those risk factors are being modified. But it would go back to what I said earlier. Blood pressure is one of the most important things that needs to be checked and monitored, because that can go undetected and just cause silent vascular damage both to your heart and to your brain. Getting your cholesterol checked would be important because high cholesterol is closely linked to the buildup of plaque in vessel walls. Screening for diabetes, doing other vascular studies, so checking your pulses to make sure there's not signs or symptoms of more diffuse peripheral vascular disease. And then looking at your weight and your tobacco use, doing the cardiac screening that we talked about earlier with the questionnaires and checking for heart rhythm. And then the more sort of imaging type studies, looking at carotid arteries. And if somebody's had symptoms of a stroke, maybe that patient gets an MRI scan or a CAT scan, even not emergently, but to see if there's been some what we'd call in-vessel damage, where there's some footprint left behind of vascular disease that tells us that, yes, they are at risk because we see this buildup of small vessel disease in their brain. So the screening process can be very simple. The most important thing is that it's done deliberately and routinely, and not just a one and done sort of thing, and that it's unfolded and unpacked in a way that's appropriate for each patient to do more detailed testing if needed. All right. And one last question. Kim wanted to know if there were any handouts or anything related to BFAST or other items for the community where they could get those.
Well, we have them at our office at Pardee Neurology Associates, which is at 835 Fleming Street. And then at the hospital here, we have, this is Stroke Awareness Month. That's why we're doing this talk at this time. But we have handouts and things available here at the hospital. And then we've kind of gone out to the community, to different areas, to try to pass these out. And then the internet's, of course, a wonderful resource. And if you type in BFAST, one of the first things that will pop up will be the American Heart Association information page about BFAST. So you can get the information almost anywhere, but probably the easiest place that you can do from your chair is on the computer and just print out that little flyer that I had a screenshot of on my slide. All right. Thank you, Erica, for directing those questions. And thank you all for the great questions that you asked and for attending tonight. I hope you found the seminar to be both informative and helpful. One of the goals I had was not to get too technical about it, but to introduce terms that you may hear. These are questions that I'm asked a lot in my practice, and so I wanted to kind of hit on things that the vocabulary and the terms that we use and the things that you would experience if you're getting worked up for a stroke, or if somebody knows getting worked up for a stroke, so that you're not so unfamiliar with the process, it's not so mysterious, and trying to demystify it some. If you're interested in receiving a pre-stroke screening, then please go to the online at pardeehospital.org stroke screening. I'm going to put up a slide here that shows that, I hope. There we go. Oops. I'm not sure There we go. I apologize. Let's get to the bottom slide here. Okay, sorry about that. So pardeehospital.org /stroke screening. And these appointments are available on Thursday, May the 20th, beginning at 4. Doctors Hobson and Sticco, they're the vascular surgeons that we here at Pardee are going to help lead this. And I will be in attendance to answer questions on site and to help with the screening as well. So if you're interested in getting screening, go to that webpage and sign up for it. I think that does it for our talk. So thank you all for joining us, and appreciate you taking an hour out of your night to listen to our talk, and I hope that was informative to you all.